Well, ladies and gentlemen, I hope I got the microphone correct. My name is Terry Khan, and I'm one of the two co-directors of the Center for Medical Ethics and Law. Philip Bay, Dr. Philip Bay over there, is my partner and co-director. I think the best welcome I can give you is to thank you all sincerely for making time to come today to join us in this multidisciplinary symposium on supporting patient autonomy. So we're looking through the registration details. We can't really know what your professional background might be, but we can guess. And there is a really interesting mix of social workers, clinicians, law, and health policymakers. So I think that most of us probably are one mind in looking forward to learning from one another in not only just listening to presentations, but participating in the Q&A, which I think will be quite interesting. For the first session this morning, we are devoting it to the theme of understanding the context of care. And the first speaker, and a very eminent one, we have Dr. C.Y. Che, who is the chairman of the Hospital Authority Clinical Ethics Committee. He'll be speaking on the hospital DNA CPR and AD guidelines and on its development, on their development and challenges. The second speaker that we have is Dr. James Luke. He will be speaking on fostering autonomy and dignified death in the end of life. And the last one for the first session today will be Dr. Joseph Kwan, who is from the Faculty of Medicine, HKU. He will talk on ethical challenge in geriatric care. So without further ado, may I invite Dr. Che. Thank you.
I'll speak for 20 minutes, so I'll try to keep my time. And then we hope that we can leave more time for discussion. So the topic for me today is the Hospital Authority DNA, CPR, and AD guideline. I'm not only talking about the development, but also talk about the challenges. Just some very brief introduction. With the contemporary development in medicine, near the end of life, many high-tech treatments are possible to prolong life. However, some of these only prolong the dying process. They do more harm than good and might be against the patient's wish, and thus may be withdrawn or withheld. However, the decision when and how to withdraw or withhold the treatment involve complex legal and ethical issues, and therefore clinical guidelines are needed. So what has HA done? Guidelines related to withholding or withdrawing life-sustaining treatment include the list in the slide. The earliest one is the 1998 guideline on in-hospital resuscitation decision, that is on DNR. And then in 2002, HA issued a more generic guideline on the withholding or withdrawing life-sustaining treatment for the terminally ill. Then in 2010, HA issued the guidelines on advanced directives. And then last year, HA updated the 1998 guideline on DNR into the new guideline on DNA CPR. And at the same time, the guideline on AD was updated. So today I'm going to limit my talk to the AD and DNA CPR guidelines on their development, and then I use half of the time on the development and half the time to discuss on 14 commonly asked questions. So within 10 minutes, I will try to discuss 14 commonly asked questions. That will be, I must be very, very brief. So I hope that will be just to lead to some further more discussion in the Q&A period. Advanced reviews of life-sustaining treatment. While mentally competent, an adult may make an advanced reviews of life-sustaining treatment specifying what life-sustaining treatment one does not want, under what situation. For example, when the patient becomes terminally ill or have developed irreversible coma. And such an advanced refusal of life-sustaining treatment helps to reduce the difficulties faced when the patient becomes incompetent. And this has legal status. When I say it has legal status, I mean that when a valid and applicable advanced refusal of life-sustaining treatment must be respected. So we must note that these two words, valid and applicable. In Hong Kong, when we say advanced directive, we usually refer to this advanced refusal of life-sustaining treatment. In other countries, such an advanced refusal of life-sustaining treatment could be called a living will, or, for example, in UK, it is called an advanced decision refusing treatment. Advanced directive, the term in other countries may mean something broader. It may include appointment of a proxy decision maker on healthcare issues. However, currently, a proxy directive on healthcare issues does not have legal status in Hong Kong currently. Okay, so in Hong Kong, when we say advanced directive, we usually mean the advanced refusal of life-sustaining treatment. Well, the discussion on advanced directive in Hong Kong actually started only just around 10 years ago. Before 2004, it was seldom discussed among healthcare professionals nor among the public. But discussion started in 2004 when the Law Reform Commission of the government issued a consultation paper on advanced directive. Before that, that is in 2002, the HA guideline on life-sustaining treatment, there was only a small paragraph on advanced directive. And because there's no such guidelines in Hong Kong on advanced directive, in that 2002 guideline on life-sustaining treatment, the guideline only quoted relevant sections from the British Medical Association guidelines in the appendix as a reference for the HA staff. Then, in 2004, the Law Reform Commission issued a consultation paper and then released their report in 2006. In the report in 2006, the Law Reform Commission recommended advanced directive to be promoted under the existing common law framework instead of legislation. The Law Reform Commission also proposed a model form, the scope of which is limited to the terminally ill, the irreversible coma, and the persistent vegetative state. But under the common law framework, this is not the only format of advanced directive that can be used. But this is the model form recommended by the Law Reform Commission. So what is the response from the government? The government in 2009 issued another consultation paper, and in that consultation paper, the government of Hong Kong suggested to make the concept of advanced directive accessible to the public. The government have no intention to advocate the public to make an advanced directive. So instead of following completely what the Law Reform Commission recommended, they only suggested to make the concept of advanced directive accessible to the public. And in addition, the government consultation paper suggested to have guidelines for the professionals and also considered whether to promote the concept of advanced care planning in Hong Kong, a concept which is related to the advanced directive, which I'm going to briefly talk about soon. So that is the government response. And then in the next year, 2010, HA issued the guidelines for HA clinicians on advanced directives. And the purpose of the guideline is to provide guidance to HA staff on how to handle AD issues in the HA setting. It is not for wide promotion of AD in HA, but to facilitate the use of AD in selected patients, for example, in the terminally ill. And the details, I just go over the areas covered by the guideline. The guidelines are available in the HA internet website. So if you are interested, you can go to the website to have a look. The details include how to make an advanced directive, keeping record of the advanced directive, assessing the validity and assessing the applicability of the advanced directive, and a discussion on the legal status and general implication of an advanced directive, and also on revoking or an AD and what to do if there are challenges to AD. There's also a special caution for withdrawing artificial nutrition and hydration in non-terminally ill patients in persistent vegetative state. And the HA also issued a standard form, and the standard form was modified from the Law Reform Commission model form. And the scope in the 2010 version of the guidelines was similarly limited to the terminally ill, irreversible coma, and persistent vegetative state, same as the limitation of the Law Reform Commission model form. But then, as I've said at the start, the AD guideline was revised in 2014 together with the form. And the main revisions are these 2 points. First of all, we have created a short AD form purely for terminally ill patients refusing CPR only. It's just to make a form simpler to facilitate terminally ill patients refusing CPR to sign the advance directive. And then we have also revised the full AD form, and we have included a 4th category, which is other end-stage irreversible life-limiting condition, in order to tally with the DNA CPR form for non-hospitalized patients. I'm also going to talk about this soon. Okay, so the revision of the AD guideline was in conjunction with the update of the DNR guidelines. So I now come to the guideline on DNA CPR. DNA CPR stands for Do Not Attempt Cardiopulmonary Resuscitation. So, as I've said, the first guideline was issued in 1998, and this guideline is an update and replaces the old one. The guiding principles in the updating process. We anchored the guideline, the principles of the guideline on Section 34 on care of the terminally ill of the Professional Code and Conduct of the Medical Council. So we follow closely the recommendation of the Medical Council, and we also took into consideration the 2002 guideline on life-sustaining treatment and also the 2010 guideline on AD. We also took into consideration international trends, local, legal, and cultural context, and also via the consultation, comment from staff and professional bodies. So what are the significant changes? First of all, the change in terminology. Now the guideline is called cardiopulmonary, do not attempt cardiopulmonary resuscitation, which is a much specific term than the previous term, just do not resuscitate. And then refinement of practice for hospitalized patients and extension of guideline to include seriously ill, non-hospitalized patients. Refinement of practice. Well, in the guideline, we have sections to include when to consider DNA CPR, decision-making process, communication and conflict management, and also safeguards. And the safeguards include presumption in favor of CPR if in doubt, level of competence of doctors making the decision, a standardized form. We have also defined effective period and also encourage training and audit. Again, the DNA CPR form is accessible by the public in the HA internet website. Well, something new to this updated guideline is the extension to seriously ill, non-hospitalized patients. The 1998 guideline was just for inpatient, not to receive CPR only. Now, this updated guideline last year is extended to seriously ill, non-hospitalized patients. Why is that? More terminally ill patients are staying at home or residential care home in their dying phase, and a DNA CPR decision made in advance for these patients may avoid futile CPR when the dying patient was sent back to the hospital. And we need to be very prudent in this extension. So in our guideline, the DNA CPR form is to be signed only when there is a valid and applicable advance directive refusing CPR, or if the patient is a minor or is an incompetent adult without an advance directive, the DNA CPR decision is made through an explicit advanced care planning process. And this form can only be filled if the patient falls into clearly defined categories of seriously ill, serious illness with end-stage, seriously ill patient with end-stage irreversible diseases. Okay, now, so we come to the 14 questions. Some of them are actually quite straightforward, but some of them would have a lot of different views, but I have to be very brief, and so comments and discussion are welcome. First of all, without specific legislation in Hong Kong on AD in Hong Kong, is AD legal in Hong Kong? Actually, this is a very commonly asked question. According to the Law Reform Commission report in 2006, under the existing common law, a valid and applicable AD refusing medical treatment has the same effect as a contemporaneous oral instruction. So a refusal must be followed. This is the view of the Law Reform Commission. So that is the Law Reform Commission. The reason why the Law Reform Commission considered that is still able to promote the use of advanced directive in Hong Kong without going to specific legislation. Okay, so this is the Law Reform Commission report. Second question. I've mentioned validity and applicability. So what to do if there is doubt about the validity or the applicability of an AD? This is from our guidelines. The recommendation is that if there's doubt, then we should continue to provide clinically indicated emergency life-sustaining treatment while waiting for clarification. And then such treatment may be withdrawn after the validity and applicability of the AD becomes clear. Well, people have questioned. Assessing the validity and applicability involves judgment, involves the judgment of the clinician, and sometimes it's not easy. Why make it more simple and make it legislate the advanced directive, and so when the doctor just see an advanced directive form and just follow without any worry about whether it is valid or applicable? Well, just to quote the UK, when the Mental Capacity Act came into force in 2007, according to the Mental Capacity Act, the doctor still have to assess the validity and applicability of an AD before following it. So even with legislation in UK, the doctors still have to use their own judgment to assess the validity and applicability of the advanced directive. Can family members override a valid and applicable advanced directive? The simple answer is no. Under the common law framework, family members cannot override a valid and applicable advanced directive. So, does it mean that legislation and advanced directive is not necessary in Hong Kong? I'll say that it is still useful. Why? Because it is useful to clarify the relationship between the mental health ordinance, the CAP 136 special section in this mental health ordinance, which says that a doctor may provide life-sustaining treatment to an incompetent patient without consent if this is in the best interest of the patient. So theoretically, this could contradict the following an advanced directive. But this issue should not affect the legal status of the advanced directive in the great majority of the cases, because in the great majority of the cases, the decision in the advanced directive usually is in line with the patient's best interest. And also, when we assess the patient's best interest, we do not purely assess the medical factors. The patient's own wish and values are actually very, very important in the assessment of the best interest of the patient. So in the great majority of cases, that will be in line. And so there's, I'm saying that legislation is important, but without legislation, we can still, the great majority of advanced directive can still be followed. Okay, so on another area, what patients are signing advanced directive in HA and how? In HA, advanced directives are made mainly by patients with advanced irreversible illnesses via the advanced care planning process. Oh, then what is advanced care planning process? Is signing an advanced directive the sole purpose of advanced care planning process? The answer is no. The advanced care planning process emphasizes a communication process to understand the patient's preference, values, and feelings about their personal goals or aspiration for care, their illness and prognosis, the available treatment options, and very importantly, involve the family members in the process. And the outcome of the advanced care planning process may not be limited to signing an advance directive. Other than signing an advance directive, a patient may make a statement of wishes and preference, or the patient may appoint a family member that the patient would like to be involved in the decision about future care, and the patient may express the preferred place of care, the need for religious, spiritual, or other personal support. And if we extend the definition of advanced care planning to minors and incompetent patients, that could be an agreement with the family on what is in the patient's best interest. Well, talking about talking about death is a taboo in Chinese society. Are there problems in discussing death issues with patient and the family? Well, the experience in the palliative care unit is that for chronically ill patients and elderly patients, they often accept the discussion of the death issues quite well if approached sensitively. So the communications approach is very important. When we see problem, usually the problem more often occurs with family members of patients with acute irreversible illness or newly diagnosed terminally ill patient when the family are unable to accept the poor prognosis. How about difficulties among professionals? Well, the professional may feel difficulty in promoting the use of ACP or AD because of lack of knowledge about ACP or AD, and they may have concerns about the legal status of advance directive, and sometimes they are not sure actually how to discuss death issues with the patient and the family members. Another question, should advanced care planning or advance directive be widely promoted among healthy members of the public? Well, actually, this is one of the recommendations of the Law Reform Commission in 2006. Actually, on this topic, different countries have different approaches. In USA, then wide promotion is recommended. But in UK, their guidelines says that we should instigate advanced care planning only if it is judged to be beneficial to the patient. And there could be a problem of wide promotion that include a patient may not have proper medical information, may not have discussed with the family, may not have, when they are still healthy, may not have understood the multitude of scenarios that may happen when, for example, when they are terminally ill, and the preference may change when the patient actually becomes ill. It would be more problematic if the specified condition is not advanced or not irreversible. Sometimes a patient may just write on an advance directive, they say that they don't want any CPR in any situation. But then the condition might not be advanced and may not be irreversible. So that will be even more difficult. And in one very big organization that promote the use of advanced care planning and advanced directive called the Respecting Choices, in their first step, so-called the first step, which is for healthy people over the age of 55, their recommendation is, first of all, appoint surrogate decision maker. And for advanced refusal, their recommendation is just limiting to the goals of care in the event of permanent severe neurological injury. So even in USA, in a very big organization, they recommend the use of an advanced directive. They do not recommend healthy people sign an advanced directive that cover many different scenarios. Okay, I think my time is coming to an end. How can an advanced directive be respected in an emergency situation? It is not easy because an advanced directive has to be judged to be valid and applicable before it is followed. In an emergency situation, we just see advanced directive. This is very difficult to say whether it is valid and applicable. How to overcome this? USA, they have developed this so-called the physician order for life-sustaining treatment. So a doctor signing a form and becomes a physician order. And in Hong Kong, this is actually the a very purpose of development of this extension of the DNA CPL guideline to non-hospitalized patients. So the HA DNA CPL form for the non-hospitalized patient serves this purpose. But you may ask a question, why do we send the dying patient back to the hospital? Why can't the patient die at home? Well, there are several reasons, just very brief. For symptom control, there could be inadequate home care support. And then even when the patient dies, there's difficulty to have the dead body sent directly from the home to the funeral parlor because of logistic issues and social issues. For those staying in the residential care home, it's unable to have the dead body sent directly from the residential care home to the funeral parlor because of the requirement in the coroner ordinance. This is a legal issue. Now, with the extension of the DNA CPR guideline to the seriously ill non-hospitalized patients, does it mean that futile CPR can now be avoided? The answer is unfortunately not yet completely avoided. This could be avoided when the patient reaches A&E, but in the transport process, the ambulance people still has not accepted our guidelines. So the reason we have been discussing with the Fire Services Department for several years. Now the discussion has come to, at the operational level, has come to a dead end. And the reason the concern is the duty to resuscitate in the Fire Services Ordinance, because the Fire Services Ordinance wrote very clearly that it is a duty to resuscitate. So regardless of what the patient said, what the family said, it is their duty to resuscitate. So this is very unfortunate. So the last question, what should be done to reduce difficulties in end-of-life decision in Hong Kong? Well, this is my own view. I think we should promote advanced directive in patients with advanced incurable illnesses as part of advanced care planning, involving the family early. And we need a government policy on end-of-life care. And that should also include revising or enacting relevant legislation as necessary. So I have talked about in my earlier slide, I've mentioned the mental health ordinance, I've mentioned the coroner ordinance, I've also mentioned the fire services ordinance. And then, of course, more education among the healthcare professionals, deaf education among the public, and then for the more elderly public, it is important, it is very useful for them to understand better the meaning of life-sustaining treatment and advanced directive, and to encourage them to discuss with the family members about the preparation of death. It is also useful for them to express personal values and preferences about the end-of-life care, but it may not be necessary for them, when they're still healthy, to sign an advanced directive before having any serious illnesses. Well, with the exception, for example, perhaps in the condition of permanent serious neurological injury. Okay, so I think I've used up my time, and thank you very much. So we can discuss further in our Q&A period. Thank you.
Thank you, Dr. Tse. I'm really filled with admiration for such a succinct and efficient presentation. I really ought to invite him to lecture to my law students. He obviously knows his stuff very well. I'm sure you have a lot of questions for Dr. Tse, but I will ask you to hold your horses until the three speakers are done, and then we can have a Q&A. I'm also very remiss in not introducing Dr. Tse to you earlier, because he's so well known, but perhaps I should remedy that now. Dr. Tse has been chairman of the Hospital Authority Clinical Ethics Committee since retiring in 2005 from the cluster chief executive post of the Kowloon East cluster of the Hospital Authority. He is one of the pioneers in the development of palliative medicine in Hong Kong. Our second speaker this morning is Dr. James Look, and he is the president of the Hong Kong Geriatrics Society. He's a double specialist with fellowships in both geriatric medicine and rehabilitation medicine. He's the president of the Hong Kong Geriatrics Society, as well as a consultant of Fung Yu King Hospital and honorary clinical associate professor of medicine at HKU. His topic for this morning is fostering autonomy and dignified death in end of life, a new care model in nursing homes. Dr. Look.
Thanks for your kind introduction. It's my pleasure to be invited here to be one of the speakers. I try to look at fostering autonomy and dignified death in end of life in our elderly populations from a geriatrician's and clinician's point of view. For Chinese, we have a tradition of 5 blessings in life, including longevity, wealth, health, love for virtues. Last but not the least is good ending of life. So end of life issues is already one of the important cultural things among Chinese. In Western countries, we have the concept of good death. Usually, it will include several elements, including individualized care, good caregiver relationships, effective doctors, staff, and family teamwork, comprehensive advanced care planning, familiar environment, pain-free management, and supporting staff, have choice and control over where death can occur is also very important. I would like to share with you a case, a real case. I'm trying to use more layman terms to explain to you. This is an 85-year-old gentleman who was chair-bound, and activity of daily living is quite dependent and living in residential care homes for many years. He has advanced dementias and also advanced Parkinson's disease, and relies on a nasogastric tube feeding. You can see this line is a nasogastric tube feeding due to swallowing problems. He was admitted repeatedly for pneumonia, and he was cared by the wife and the son, and there's no advanced therapy before dementia. Again, he deteriorated again and was admitted to hospital. In the final journey, he was again put on blood tests by the doctors, IV drip, big gun antibiotics, and in the hospital, a DNA CPR form was signed. However, developed many bed sores and also pneumonia, and required a non-invasive ventilating machine. You can see the shadows here, which put on the face. However, he died 6 days later in the middle of night in the medical ward. But the wife and son, even they rushed to the scene, could not say goodbye to the patient. This is happening every day in our acute ward. But the family members did have a huge reactions. They cried and became emotional in the ward. They started to complain. We created a lot of troubles to the ward staff. They said they had not been informed about the patient was dying. Otherwise, the daughter in Canada can come back. They were not called immediately before patient died. In the hospital, the visiting hours were too short. They are not allowed to stay longer to take care of the patient, except during the visiting hours, which was quite limited in the medical ward in Hong Kong. There's no time to say goodbye, and then they all started to complain about the nurses who attitudes, inappropriate languages, and we need to have refer the case to the PRO. So the question is, was this death a good death? If not, why? Maybe you may agree with me that he's not having a good death. There's no advanced care planning. The patient still receiving predominantly curative approach by the doctors, even in the end stage of life. The lack of quality of life care in the hospital because the staff is so busy taking care of acute patients. And also they do not have much training in handling bereavement. And there's no bereavement services, be it psychosocial or spiritual. The patient was dying in the unfamiliar environment, and there's no family members around him when he died. And last but not the least, the family actually has not prepared for his death and still have some false hope because the patients are treating him quite actively before he died. So we are facing a lose-lose situation in a lot of medical older patients in Hong Kong with chronic irreversible illnesses. This is the reality in Hong Kong. No matter you're living at home or in residential care homes, when you get sick, you go to the emergency department, A&E, right? And then after certain investigations, treatment, you are deemed need to be admitted. You will go to acute medical ward. And then you have another set of investigations, clerked by the houseman, seen by the MOs, and also clerked by the medical students, with X-ray, IV drip, everything done before you die. My impression is that our system is excellent but it is a system of the 70s. It is unable to meet the needs of our chronic patients with, in the year of 2015, 2016, and etc. Dr. Jay had talked about some obstacles in dying in place, and social taboo may be one. Practically, depreciations of property price may be one, right? You don't want to, in Hong Kong, I think you know, property is important. You have a patient die in the home, that home will become hongjiat, right? And then the property price will depreciate. Even in residential care homes, they dislike people to die there because they may affect their business. The lack of medical support, few doctors wish to go out to the clinic to certify death, lack of study to show whether we want the elderly want to die at home or in the residential care homes, lack of training, lack of government policy support, lack of death educations, and legal obstacles. I'm sure Dr. Bay will talk more about the legal aspects. Just one slide showing what happens in Hong Kong. This mosaic pattern of pictures are the aged homes in Hong Kong in my cluster. Okay, I'm sure in the newspaper and TV recently you'll see a lot of this news recently. So, but one of the coroner ordinance said that if you die in institutions other than nursing homes is under the hospital registrations, but most of the RCHs in Hong Kong are not under the hospital registration, so they need to report to the coroner. How about in Western countries? You look at all over the world, in Europe, in Australia, in America, more than 20% of the elderly actually die in the residential care homes. In Asia, Taiwan, Singapore, even Japan, they have this sort of figures, but nearly zero in Hong Kong. You may know that we have 8.5% of elderly are living in residential care homes, amounting to about 70 to 80,000 in total. And they are characterized by multiple diseases. And one of my studies showed that you look at advanced dementia, more than 1/3 of the elderly died within 1 year. So it is a huge mortality rate, and they are in need of end-of-life care indeed. Do we have a market? What are the wishes of the elderly? One of the studies done in 2011 by our team showed that 35% of elderly wish to die in their residential care homes if they are allowed to do so. One of the nursing homes is called the Haven of Hope Nursing Home. They have piloted, I shouldn't say pilot, they have carried out the end-of-life care and die in place for more than 10 years. And they have good results. More than 100 elderly die in their nursing homes. But they are nursing homes, so they are legally can die there, but without reporting to the coroner. But this model cannot be applicable to all aged homes in Hong Kong. Because of this background, our team has carried out a pilot end-of-life program in residential care homes. I use the word pilot because we have no extra resources. We do it from our own will in a small scale. And the team carried out this is the Hong Kong West Community Geriatric Assessment Team, the Hong Kong West CGAT, inside our hospital. Okay, we started in 2009, September 29th, so it's a 3-9 here, 999 day. And we carried out in 2 homes. One is a self-financed homes, the other is a nursing homes, okay? This is me 6 years ago, still looking young at that time. Anyway, we have some selection criteria. We look at patients with organ failure, heart failure, chronic obstructive airway diseases, renal failure, that sort of patients. We also get some patients with cancer. However, we don't duplicate. If the patient is under the hospice team, we have another team called the palliative medicine team. We will not see that patient. We do not want the duplication of services. Advanced dementia, of course, and degenerative neurologic diseases such as Parkinson's disease. We choose these patients by looking at their comorbidities as well as their general conditions, as well as we use a surprise question to see whether they will die within 6 to 12 months. However, prognostication is difficult for these patients, except cancer cases. We offer two pathways for the patients. One is called the hospital from Yilgeng Hospital pathway. The other is called the emergency pathway, called the A&E pathway. Let me explain to you this pathway separately. From Yilgeng pathway is a pathway in which we support the patients in the residential care homes, but when they deteriorate, they will immediately or quickly admitted to the hospital to carry out end-of-life care. But this bypass the A&E and bypass the acute hospital, because from Yilgeng Hospital is a subacute geriatric hospital. They don't need to go to Queen Mary Hospital anymore. On the other hand, the emergency pathway is that we will see the patient even more frequently, and when the patient deteriorates, they will not go to hospital. We will support them as long as possible until the last moment, and the patient will carried by the ambulance to the A&E or the Queen Mary Hospital, where the patient will be given a single room, the family around them, around the patients, and the patient finally will succumb there, and they were certified by the A&E doctors, and the depth cert form 18 will be filled in by our team. We have seen the patients within 2 weeks. We need to enhance all our support in order to carry out this program. We have a link geriatricians and link nurse to see the patients frequently. Unfortunately, only office hour at this moment because it's still a part of the program. Obviously, we will do the advanced care planning. We will sign the DNA CPR non-hospital form. We hold family conferences. We also assess the bereavement issues. And we provide timely consultation by the link nurse as well as by the geriatricians. And we also engage the private doctors, the VMO, visiting medical officer, to give ad hoc problems support to the patients. And because of this program, we have carried out for several years already. We'd like to have a review of how successful of this program is, whether it's really helping the patient autonomy or not. You can see this photo was taken in A&E. A patient will die at A&E in a single room, and the families are around the patients. So I look at 64 patients. You can see it's not a huge number of patients. Among them, 23 were male, 41 were female. They are quite old, 87 years old. We range to 108. So this is the oldest patient I've ever seen, 108. But in my ward nowadays, just today, there are 3 to 4 patients more than 100 years old in my ward already. So you can see the aging population. I can sense this. And it's good to be a geriatrician because I'm always younger than the patients. The age is always more age than me. The length of stay in the residential is 45 months. So they see their homes as their homes. I mean, they see the OH homes as their homes. However, no one had made any advance directive despite our proactive promotions, partly because a lot of them have dementia already. Among the case mix, we can see that most of my patients in the program, nearly 70%, is in the dementia disease trajectories. Some 9% are in cancers, and a few of them, 22%, were having organ failure. So dementia, advanced dementia cases contribute most of our patients. 2/3 have chosen the usual pathway, the hospital pathway, but 1/3 actually chose the more innovative pathway called the AED pathway. Whether we are able to reduce attendances in A&E, total admissions, and bad days are important to them, to the managers. Not to me, actually, but to the managers. So we still need to do the figures. And in HO, they have published some figures in the last 6 months before death. They have these sort of figures. A&E attendance 2.9, but my study, the cases is 2.67, slightly lower, but this already including the episode of dying in A&E. So including all the episode of A&E attendance. Total number of admissions is markedly lower. Total bed days used is markedly lower in our patients. Okay, I now just spend the last few minutes to talk about the 9 cases which pass away through the AED pathway. Okay, Among the 64 patients, 9 cases passed through the AED pathway. Actually, today, 11 cases have passed through the AED pathway. But when I did this study, 9 cases have passed through the AED pathway. They are quite old, and again, dementia are the contributed to most of the cases. And this table is a bit complex, and just show you several points. One is that there are lots of different symptoms, like shortness of breath, edema, and swelling of legs, pain, shortness of breath, that sort of things. But all these symptoms were under the management of the residential care home staff with support by the CTAT nurses and doctors. In the 1 month before death, they need a lot of doctors' interventions as well as nurses' interventions. Most of them require some oxygen in the residential care homes. And this take is CPR by ambulance. Even they have the DNA CPR form, except 1 cases, all cases were resuscitated to a certain extent by the ambulance. And we are able to fill in the depth cert within 1 day, 24 hours. These are the symptoms I summarized again. You can see poor feeding, confusion, edema, pain, and shortness of breath. All these symptoms happen in the last 1 month of life in the residential care homes, but all these are cared by the residential care home staff with support by our team. So this actually can have replaced the hospital staff to take care of the patients. Our service did not end after the patient died. We will join their memorial service. They will usually hold memorial services after an elderly died. You can see it is one of the memorial services. And this is my nurse, who is a male nurse, joining the memorial services. We can see the family members sitting here, the staff sitting at the back, and social workers sitting on the side. We all solemnly condolence the death of that gentleman, and we allow the family to express their feelings in the memorial service. This is the daughter of one of the patients. He cried, but he thanks us. He thanked the team. He said that my father said that this was his home. And then the staff also shared the feeling, I love this gentleman very much, and I'm proud of taking care of him in the last journey of life, that sort of things. So everyone seems to have a win-win situation now. Before the patient died, this is one of the elderly lady, very charming elderly lady, but she passed away 2 years ago. But before she died, we established a very, very close relation with the family. Because trusting the doctor is very important. You can't find a stranger doctors to take care of the patient. They don't have trust on you, but you need to build up a good relation with them. The staff too, they just love the patient very much before the patient passed away. So, last but not the least, way forward, taboo, change the taboo in the Chinese culture, more proper educations, as already told by Dr. Zhe, government policy supports, training of the RHC staff and general practitioners, training in coroner's rules, academic researchers are important, and maybe good death should be one of the key performance indicators of healthcare services in Hong Kong. So this is the end of my presentation. I hope you understand what I'm talking about, and hopefully when we get old, we can have more autonomy and dignified death in the future. Thank you for your attention.
Thank you, Dr. Luke. I can only say that at the end of life, I would also hope to be cared for by a physician like you. Our next speaker is Dr. Joseph Kwan. Dr. Kwan is a UK-trained academic geriatrician, and he practices a senior consultant in geriatric and stroke medicine for 8 years before joining HKU in 2014 as clinical associate professor. He has wide academic interests in conditions affecting older people, including cognitive decline, ferality, and sarcopenia. He is also an organizer of the Medical Humanities program at HKU. And his topic for this morning is ethical challenges in geriatric care. So, Dr. Kwan.
Thank you. Good morning, seniors, ladies and colleagues. I'm very pleased to be introduced and invited here to talk amongst so many colleagues here. And I could see people from the law faculty, we see clinicians, very senior geriatricians, and I hope we can have a fruitful discussion afterwards. I suppose where I'm coming from in this talk is concentrating on ethical challenges. I'm not talking about clinical challenges, I'm not talking about resource or process, I'm talking about ethical challenges in what we do every day. And I would like to tell you that the challenges occur very rarely, but unfortunately, I see it in everyday practice, every ward round, every clinic, there are ethical challenges. And that's why I think geriatric medicine or gerontology is slightly different from some of the other organ-based specialisms. And it has taken us a much longer time to be recognized as a specialty, not just in Hong Kong, but all around the world, I think led by the UK. And I'm very fortunate to have worked there for about 8 years as a consultant, senior level, before coming back. So I've seen the differences in the services, differences in the ethical frameworks, and differences in the society and the ethical issues related to ageism, etc., which I'll touch on. So I don't have any conflict of interest for this talk. And I'd like to thank Dr. Jie and Dr. Look for laying the groundwork for this talk, because I think they're all very relevant. I'd like to start with a story, because I think stories tell many more ethical issues than other ways of explaining. So this is a true story from last week, actually. This is a gentleman I saw on the ward last week. He's an 85-year-old gentleman who lived in an old age home. He was actually quite a rare specimen, old age home resident who's independent, who went out every day, who goes swimming every day, and goes buy his own newspapers and drinks in the shops. He only just lived in the old age home. He was physically fit and mentally able and not confused. He was mobile and able to look after himself. But he was admitted to our geriatric unit. And the reason why he was admitted was apparently he had agitation and unstable mood. He was shouting at the old age home staff, and he was apparently confused and queried delirious. So that was his admission reason. So we delved a bit deeper into the story. And on admission, he was well, he was calm, he was talking to us, cognitively sound. He had no abnormal physical problems that we could see. So we phoned the old age home staff, and we took the history a little bit more detail. Actually, he lived in the same room as his wife. So his wife was admitted to the old age home, and he went to live with her. He was very close to her. But his wife had advanced dementia and stroke, and she was dependent for all the care from the staff. She had no understanding or communication with other people, but she was physically restrained, both in the limbs and the trunk. And she was restrained 24 hours a day, except for maybe going to the toilet, etc. And she was fed by a nasogastric tube, so that is a way of feeding someone when they can't swallow anymore. And she was incontinent, both of urine and feces, and she was wearing a pad. So her husband was living in the same room, and her husband was the one who was admitted. So what happened? Actually, one day, he couldn't bear seeing his wife suffer anymore, and he took off her limb restraints. He untied her. He freed her. And then what happened was his wife took off her pads, diapers, and she ended up being covered in feces. And guess what? The husband was told off very severely. He became very agitated, and he argued with the staff. And the staff said, "You're going to the hospital because you're confused, you don't know what you're doing, you must be sick." So what did he say? He says, "This is inhumane and cruel." These are his words, I'm not paraphrasing it. "Is this how you treat an old and defenseless lady? She's not an animal." So these are the three things that he told me was what he said to the staff. So as you can see, there are a number of ethical issues illustrated in this case. And this is a picture I'm sure some of you will know is the death of Socrates. And I'll come back to this picture in just a little while when we've talked about some of the issues. But you can see that in terms of ethical issues, there are a number of things which worried me regarding his care and her care. So if we go to the 4 principles of biomedical ethics, I don't want to talk about what Zhanzu is going to talk about later on. She's a philosopher and an ethicist. So, but these 4 principles I will just briefly mention by Beauchamp and Childress in their book in 2001, talked about 4 main principles. One is the respect for autonomy, which Dr. Luke has talked about. What does that mean? It means respecting the decision capacities of someone who has mental capacity and is able to make autonomous decisions, and enabling the individuals to make reasoned, informed choices. The second principle is regarding beneficence, and this considers the balancing of benefits of treatment against the risks and costs. So in this case, I would like to bring to the attention, for example, of the physical restraint and for example, the nasogastric feeding of someone with severe dementia. The health professional should act in a way that benefits the patient. It's the overarching principle here. The third is the non-maleficence, the avoiding the causing of harm. And so the healthcare professional should not be doing something which could potentially be harmful. And here we can have some examples in this case, as we said. If the treatment may have some harm, if minimal, the harm should not be disproportionate to the benefits of the treatment. Of course, every treatment could have harm. Paracetamol has harm. Antibiotics could have harm. But it has to be balanced against the potential benefit and explained to the person who's taking the treatment. And the fourth principle being justice, distributing benefits, risks, and costs fairly. So the person in a similar situation should be treated in a similar manner. And my next example should demonstrate that. So another story was one from outpatient department from 3 weeks ago. I was talking to this patient who came to see me in the geriatric medicine clinic. She's 91, she had left breast cancer and was reviewed in a government hospital clinic. So she's a newly diagnosed breast cancer patient on the left breast. She has a fairly uneventful story of diabetes and blood pressure, but she was frail. She could only walk about 50 yards. She had 2 domestic helpers to help her at home, and they did everything for her. She was frail. She loved going out every week in a wheelchair, pushed by her helpers, to go down, to do some exercise in the garden, and have a walk near the sea. And she has visits by her grandchildren, and they played in her home every week, and she really enjoyed it. So in terms of quality of life, she said she was enjoying her life at that point. And most importantly, when I talked to her, and at the time of when she saw the hospital clinic for the breast cancer, she was mentally sound and communicated very well. Anyway, so this is not to my clinic, this is to the breast cancer surgeon clinic. So she attended the breast cancer surgeon clinic with her son and daughter-in-law. And the breast surgeon explained, surgery is the best option here for you, madam. But there are some medications, they're not so good, but you need surgery. That's the best option here. No. She said no. She didn't want surgery. Why? I just don't want surgery. I don't want to go through surgery. But she agreed to taking medications. So the family said to her, I hear this most weeks, "Oh, just do what the doctor says. You must have surgery." The person said no. The patient said, "No, I don't want it," and the surgeon gave her some medications on her way. Then the family persuaded her to go to a private surgeon. So she attended a private surgery in a private breast clinic in a private hospital. And the surgeon was much more forceful this time and said, "Surgery was the only option for you, madam. There's no other option." She said, "No, I'm 91. I've had a good life. I don't want surgery, thank you." So the argument continued, and it carried on until she backed down. Actually, unhappy, in despair, not wanting any more arguments with her family. And she reluctantly signed the informed consent form to allow her to have surgery. So she was admitted, of course, to the private hospital where she underwent further blood tests, X-rays, CT scan, a PET scan, which is a positive emission tomography scan, very expensive, close bracket, bone scan, and other tests in order to prepare her for the surgery, which she has now signed in informed consent form for. Her breast was removed 2 weeks later, and the whole treatment cost $250,000 and counting with her further follow-up. So in your head, in your mind, you must have some ethical concerns or issues that you think, that's not something that is something that I feel comfortable with, that is something I might feel comfortable with, but you may all have different opinions, and you may all have different views, and according to what we already said, with the 4 principles of the biomedical ethics. In terms of autonomy, this lady was mentally sound and cognitively intact. And in our head, in our mind, she was able to make a conscious and she had a mental capacity to make that decision for herself. The relationship between the family and the patient is that dynamics we always have to take care of in our geriatric care on an outpatient and inpatient basis. Are we doing good to a patient? You could argue that, but in a 91-year-old, do we have a good research evidence that for this population, this is the best option? Non-maleficence, if it's something the patient doesn't want, the surgery clearly has harm in a 91-year-old. Have we clearly delineated the risks, the surgical risk, the anesthetic risk, and the fact that it will change her image of her body without a breast? Justice. Is this something that the HA in a government hospital is receiving in the same way as a private patient is receiving in another circumstance with another amount of resource? Are we treating people in a similar way because they have similar backgrounds? Just a couple of words about aging, we are all age. Time stops for nobody, and as we age, we become more frail, we become physically and cognitively frail. On top of that, we have social, family dynamic problems, economic concerns, social, living environment issues, etc., especially in Hong Kong. We can have 3 or 4 generations living in the same household, but all the younger households could be working or in school all day, leaving the 91-year-old at home by herself, unable to do things, if that's the case. So we see a myriad of complex, interlinked, physical, cognitive, social, psychosocial issues. It's very common to hear this: oh, she's 91, she's so old, she must be weak, frail, unable to walk, unable to go to the toilet, can't feed herself. Can you really wash your hair? Do you choose your own clothes in the morning? Etc. She must be like this. We make assumptions, we as in the society. But if you use a humanistic viewpoint, no, actually there are exceptions, and every individual should be viewed as an individual human being with their own properties, with their own good and bad points, abilities, capabilities. So we see lots of older people enjoying meals with their friends, with their family. We see older people running along the coast every morning. So no, they're not. It's not just because they are 85 or 90 that they have to be regarded as like that. And in geriatric medicine and gerontology, in Hong Kong and UK and other places, we practice patient-centered care, or what's called holistic care, as in the whole person. So we like to think that we practice respect and values the uniqueness of each person. We pay a lot of attention to dignity and sensitivity to the situation, using our compassion and humanistic values. We like to develop the patient's own choices, give them choices and options, and empower them to become healthier and make their own decisions about treatment. We like to have a positive aging attitude to promote quality living. However, globally, we see a lot of ageism. Because you are 65, you are much more difficult to get X or Y. Because you are 55, it is much more difficult for you to get a job or to drive, etc. We see a lot of paternalism. I tell you what to do and you do it. And I see that in Hong Kong more than in England. There's much more. The doctor says, take this tablet 3 times a day, etc. I don't know if it's a cultural thing or it's a pressure thing, but the funny thing is the patient and the family expects paternalism. They think it's normal to be told by a doctor or nurse, this is what you should be doing. But is this what we want? I would just like to take an example of physical restraint and chemical restraint as well. I'm aware that we have experts, international experts here on physical and chemical restraints. Anyway, back in 2004, over 10 years ago, in old age homes, 63% of residents were physically restrained using the standard definition. In 2008, it's about the same, about 68%. And in 2015, I've just looked at the figures again from old age homes. We have about 1,500 residents, and the situation's similar. it's about 60% are physically restrained, and about 1 in 5 are given medication to restrain them. So this is to calm them down, things like antipsychotics. And in about 1 in 6, they have both physical and chemical restraint for that same person. Hong Kong is not the highest in this regard. We have a paper in 2009, and there's international collaboration. It shows Hong Kong is on the par with Canada and Finland. I'd just like to tell another 2 or 3 more stories with pictures. So this is a patient who has severe dementia, unable to communicate, and he came in with a pneumonia and unable to breathe. But as you can see, because of the confusion and the delirium, and that was the reason for restraint, he was physically restrained both in the limbs and the trunk, to the point where he could hardly move his chest when he was having a respiratory distress. And he was trying to adjust his oxygen because he tried to catch a bigger breath. But the physical trunk restraint is pushing him down towards the bed. This is a very mild patient. I was able to communicate with him, talk to him, chat to him, and he could walk to the toilet. But when he's in bed, the nurses tied his arms to the bed. Even during a meal, he was just able to put the spoon to his mouth. Otherwise, he would be unable to feed himself. He was unaware of why he was restrained. This is another occasion where, sorry, it's a bit bright in the background, but this is a dying patient. Yes, end-of-life patient that we've been talking about with end-stage dementia. What you can see here is a tube going into his nose for nasogastric feeding. Yes, you guessed it right. He was physically restrained. Both his arms, and actually I couldn't show it here, and his legs were tied up to the bed. Is that really necessary? Is it a good death? Is this what we are promoting as a society? Is how we treat older people? What about this lady? She just had a stroke. She's able to walk with a physio. Her left arm is the one that's been paralyzed, and her right arm is the good one. Her right arm is the good one. It's the only good one. And guess what they did? They tied her right arm down, the only good one that she had. So she's unable to feed herself. So her daughter has to come in every day to feed her because she is now dependent on other people. No, she was not violent. No, she was not aggressive. She didn't push. She didn't hit people. She didn't shout. She wasn't aggressive. So there's this balance between risk and autonomy that we use, the authority uses to talk about the reason for using restraint. And if you have surplus safety as your overarching aim, then what you're saying is safety trumps all. So if your overarching aim is you want to have a safe environment, you don't want people falling over, you don't want people pulling their diapers open, you want safety over everything, then you will reduce your level of autonomy. And you often hear this phrase, this restraint keeps them safe. You are working to the good of the patient, surely, is what they're looking at. But we have good evidence from local studies, from international studies, restraint can be reduced. It can be got rid of and avoided altogether. We have very good trial evidence from randomized studies that it is possible. But we also have good studies, it is harmful. Pressure sores, falls, etc. we are doing maleficence. So in most cases, I'm not saying, never say never, never say forever. Physical restraint is avoidable and unnecessary and can cause harm. So we do have this ageism and paternalism which is throughout our society at the moment, and my view is what you allow is what you will continue. I'll just quickly touch on these three theories which I've heard being used for the justification of restraint use. One is consequentialism. I'm sure some of you have heard of. The other one is deontology, and the third one is virtue ethics. What is consequentialism? It is where the correct moral response is related to the outcome or the consequence of the act. So you do something because your outcome is what you want. It is maximizing the greatest good for the greatest number. So I hear this used as a justification for restraint use because there are only 2 or 3 nurses to look after 40 residents. So how can you expect 2 or 3 nurses to stop people falling or give good care? So the ones who might fall or might get out of the bed should be tied up so that the nurses don't have to keep going back to get them back into bed to explain to them what's happening. So by tying them down, you are maximizing the greatest good for the rest of the residents. Oh yes, this is what is being justified in that way. So what you're doing is, by doing this, you're improving the care for other residents. The next one is deontology, which is based on the duties and the rights and respects of the individuals. So it's your intention which is the value and the important focus here. And the third one, and I like to see that if we can be able to move forward towards this one, is to do with virtue. Virtue as in the moral character of the individual. So if we say that we are trying to improve the virtue or enhance the virtue of the clinicians, then hopefully what we do as a result comes from the virtue, and the ethical practice will follow. But at the same time, ethics can evolve. Ethics is personal, and ethics is subjective to you as a person. So your ethics could be different from your ethics in a way, or what that means to you personally, or your circumstance, or the circumstance of what you're trying to apply the ethical practice. So lastly, coming back to the death of Socrates, as you know, he was sentenced to death because he was teaching the students what they said was things against God. So he was told to take poisoned hemlock to kill himself. And he is just about to receive the bowl of poisoned hemlock given to him by one of his friends or followers. You've got people sitting at the end of the bed, looking away, just denying things which are happening. I don't want to see what's happening. I'm just don't want to know. I don't want to be part of it. And then you have the compassionate friend who has a hand on his leg, probably telling him, you'll be okay. But of course, Socrates is a very strong person, and he wanted to use this lesson to teach other people about his teachings and death. So the way I see it is, do we want to be handing something harmful to an already dying person, like the person they're handing over the cup? Or do we want to be the compassionate person who wants to understand and give care for the good death of that person? I know there will be people who say, this is impossible, we can't get rid of restraint. It's been said, it's been talked about for many years. Yes, I will have enemies who tell me, point fingers at me, But as we know, you have enemies, good. That means you've stood up for something sometime in your life. Winston Churchill said that. So I hope that we can stand up together to promote ethical care for our older folks. I'd like to acknowledge all my team, and also we have permission to use the photographs of the patients. Thank you.
Sorry, I'm not sure whether that counts as a wardrobe malfunction. I'm not 91 yet, but I can't pick up my clothes in the morning, and I had reached in the fridge this morning to retrieve what I put in a microwave 5 minutes earlier. So I think I would also like to have people like Dr. Kwan taking care of me when I get to the age. Well, I've been blessed with really obliging and punctual speakers. So we do actually have half an hour for the Q&A. So maybe I should just start off by inviting the speakers to comment if they have any comments on each other's speech. And following that, we can then open the floor to questions. I would just ask you to limit yourself to just one question. And if you could also please identify yourself, your affiliations, and use the microphone, press the button so that we can hear your question. So perhaps the speakers first. The speakers are also entitled to ask questions. You can also ask questions of my co-director, Dr. Philip Bay. I think he's quite an expert on this, although he deals with patients after they die.
Sorry, my name is Nicholas Miller. I have two questions, one for Dr. Luck and one for Dr. Kwan. The first one for Dr. Luck is, when you were talking about your old man in the home who had been admitted and so on, you mentioned that he developed pressure sores in what, if I understood you correctly, was a very short space of time. Now, I'm a lawyer, I'm not a doctor, but my understanding from dealing with doctors is that pressure sores are a sign of neglect. And I know quite eminent consultants in the UK who would argue forcibly that any pressure sore is something that should not be allowed to develop if somebody is given proper care. Would you care to comment on the existence of pressure sores in somebody who was admitted for such a short period of time?
Thanks for bringing up that. That gentleman, which I show you, was quite ill, and he was put on ventilator and kept on bed 24 hours a day. I think if the nurses have done a good job of turning the patients every 3 to 4 hours with a suitable mattress. However, the patient did have a lot of other risk factors for pressure sores, like he was in poor conditions and low hemoglobin, no nutritional status. So even you did all the things, sometimes pressure sores still develop. So I don't think it is a sort of neglect, but it's the patient's general condition is too poor. So even whatever you did in the hospital, they may still develop some pressure sores. So that's my comment on this gentleman. But I can't say, yes, you're right, pressure sore is a poor outcome of our patients. So we should try our best in hospital, even in age homes, to prevent pressure sores. So that's what my comment about this, your question.
Okay. Number two, Dr. Kwan, I'm not going to drop you in it and ask you to comment on Dr. Luck's response. I'm not going to, albeit if you wish to, it's up to you. But my question to you is, I recently attended on a lady who was the widow of a colleague of mine who'd had a stroke, and she was in Tonghua Eastern Hospital. Most of the time, she was perfectly normal, perfectly rational. The care she was given, I'm not complaining about at all, but she was restrained. She was exactly like the lady you gave the example of. The stroke on the left side, and her right side was restrained, and there was a body belt round her. Now, I argued with the staff. I was ultimately told, very politely, go away. It is nothing to do with you. You are not a member of the family. You have no right to have a comment or an opinion about this, even though I was visiting her daily. She was a permanent resident, she was a Filipina, but she was a permanent resident of Hong Kong. Her only relative in Hong Kong is a domestic helper, who was her daughter. Her daughter spoke hugely inadequate English and minimal Cantonese, so her daughter could not effectively communicate with the nursing or hospital staff in any way. Now, to what degree should hospital staff, A, restrain like that, and B, when somebody actually has the effrontery to say, excuse me, why are you doing this in the context of this particular lady, to what degree do you think they should be listened to?
Thank you. You have lots of questions within that one question, of course. And it's quite a complex situation because this person sounds like doesn't have a close relative in Hong Kong at the time who has so she didn't have a legal guardian to make health-related decisions. Is that correct?
It's complicated because she had a stroke. I went to see her in the Cheshire home. She made a will at my advice. She made an enduring power of attorney. Where I was appointed the attorney. She then had a second neurological insult of the doctors never sorted out what it was, but we've got suspicions. And then thereafter, she was 80% of the time still, I would say, compos mentis, with occasional days when she was fed up of being in hospital, she would become distressed. Now, you could say that she was or was not compos mentis on those days, but the next day she would be back. But my point isn't as to that, because I could have gone and registered the enduring power, but that would have given me no influence whatsoever as to her hospital treatment. It's purely economic. I could have trotted off to the guardianship board. Well, I mean, the greatest respect to anybody from the guardianship board here. It's a bureaucracy in Hong Kong, and let's forget bureaucracies in Hong Kong if we want results quickly. Really sorry. So it comes back to my basic question. To what degree should this lady have been restrained when she didn't want to be anyway? She was quite capable. Sometimes she'd go along with it for ease of, you're in hospital, you depend on the staff, and I'm not criticizing the staff. To what degree, however, should somebody like me, who is not a family member, but is concerned, has some legal connection with her by virtue of the enduring power, be entitled to voice opinions and to have those opinions at least substantively listened to?
I think currently, I'm sure, Dr. Luke, you have, and Dr. Zhou, you have your opinion. Every institution currently has its own rules and regulation regarding the use of physical restraint. And they have to sign a particular form to confirm that, in their opinion, in the opinion of a senior person, the potential benefit outweighs the harm, and the necessity is it's a last resort. It has to be the last thing that that person has to endure. So it's the last resort, and to me, a lot of those forms are paperwork, because if the staff wants to restrain the person, then it's a matter of a signature on a piece of paper, and so it's like a bureaucracy in a way. To me, what is much less clear is how do you define. So, for example, if someone gets out of, for example, if someone is having drips for various very important medication, and every 5 minutes the person is pulling the drip out that is giving them some vital medication, and the person wants to get better, but is confused, for example, due to a recent stroke or a hit on the head, but they're normally very compos mentis, then you can argue that maybe if you restrain them for a short time to give them the right medication, the person will improve to an extent that they can start to be less delirious and go on the road of recovery. But in the most circumstances, the use of restraint in our hospitals and in old age homes are more because, well, for convenience in a way, which is because there's so few nursing staff and so many residents, because of the recurrent falling risk of these residents, that the staff are worried about these residents falling, so they want to tie them to the chair. But as we know, this particular way of treating someone is avoidable, and there are ways that you can get around it. We've proved it in clinical trials. It is avoidable. It is not necessary. So I'd like to hear the opinions of Dr. Look and Dr. Jia as well.
I think as every hospital under the HA has a standard guideline of when and how to use restraint. So they must follow all the guidelines. I'm not defense on using restraint, but I'm sure every patient in the hospital have passed through this sort of thinking process before applying the restraint. But having said that, there should be ways that even under this guideline, restraint can be avoided as much as possible. Your question of who can influence the nursing staff to reduce restraint is dependent on the hospital policy. Usually when the nurses apply the restraint, they will discuss with the so-called relatives or the person who has been taking care of the patient, know the patient well, as a dialogue, and then after agreement, even the doctor knowing that, then they will apply the restraint. So I'm sure there may be other people that they have talked about, discussed before the applying restraint with your particular patient. I'm not sure, but usually it is the way to do.
I wonder if I may follow up the question with one to all the speakers. From a legal point of view, there could be an argument that if you restrained a person who is competent for convenience, then you're open to challenge in the tort of trespass. Standard guidelines are no defense to an action in trespass. So, has any patient in Hong Kong so far challenged this? The right to freedom from physical interference, the right to physical freedom has been described as a basic human right, which the law, the common law in Hong Kong, will strenuously defend in the torts of trespass to the person and under the tort of false imprisonment. So I wonder if you have any comments on that.
Personally, I personally don't know, but there might be some senior colleagues here who might know of cases of.
All the speakers have very eloquently pointed out all the issues about elder care in relation to ethical principles. One thing that they perhaps have not highlighted is that things have been like that for ever since the 1980s, since I started working here. And we have to ask the question why this is, because there are lots of active dialogue with respect to ethics and law, etc. And then there is the medical care institutions, because after all, most people die in public hospitals. Now, so I think most people listening to these stories say, this is not right. I mean, this human thing is bad. Just like you keep reading horror stories in the newspapers every 5 years about care in OH homes. So I think that if we're going to move forward, we've got to go beyond this sort of talking to each other, who all believe in the same things anyway, as to how we're going to move things forward. Now, is it possible, for example, to talk to the people who make policy, people who make rules, people who are concerned about quality care, to feature clinical ethics as a major component, and to say that if you ignore all these principles, you are not providing quality of care. Right now, it does not feature anywhere in the decisions, except perhaps right to the cardiac resuscitation thing. Now, the interface of the legal profession is very interesting. After all, it's the Law Reform Commission who pushed for advance directives. And yet, it's legal anxiety that's making the administrators in hospitals to behave in the way that they're doing. For example, if you don't tie people down, their reason is that somebody will fall, and it is true. People are so frail, actually, that they will fall anyway, even if two people are supporting them. And then what is happening now is the relatives are suing the hospital. They're suing the staff. So the people who are in the front line are really being squashed because the guideline says you have to do it, and if something nasty happens, is the hospital authority going to defend you because you have not followed guidelines? So right now, the law is acting in opposite directions, and I think that we need to tackle these big questions. The front line is really in a bad way because nobody wants to do these things, and yet if they don't, they're being blamed, right? So I think unless we tackle these really big issues, rather than, of course we need staff education, all that, we need to raise awareness on the part of the public as well. But from the point of view actually doing something meaningful, I think somehow we've got to tackle this interface.
Thank you. I wonder if Dr. Tse was going to say something.
Well, I think Jean just raised a very broad question. And my simple answer is that, as I put in one of my slides, I think it's really important that the government had a policy on end-of-life care. So with a very broad coverage on various aspects, including the legal, education, professional, and social, of course, yeah.
Okay, I'm Mary, a psychologist. I used to work in a HA hospital, so a lot of reminders about the days. And actually, thanks Dr. Kwang and Dr. Lok for sharing sad stories about what is happening in the hospital. So hospital is really, to me, never a peaceful place to die. And actually, last year I started to talk with my parents about the possibility of dying at home. And I hope lawyers here could help to facilitate this condition. I mean, home is a place where they really feel familiar with and be themselves. And it's very important. And I would like to ask Dr. Jie about advanced directives. A few weeks ago, a 30-year-old young woman mentioned to me that she was being told that she have to pay over $10,000 to make an advance directive. I mean, this young lady is physically healthy, but she started to think about autonomy, about having their own choice about how to die. I think pushing for more public education on death and dying is important, but talking more about a choice is also important. I mean, given, as Dr. Kwan said, it's a paternalistic culture. So, but the young generation are more aware, and really want to have know that they have a choice. So I hope that more discussion about this is important within the healthcare setting as well as in the public sector.
Yeah, I agree that it is more education, more discussion is very important within the society on advance directive. It's very strange that you told me that you need to pay how much? 10,000. Well, I mean, anybody, according to the under the common law framework, anybody can make their own advance directive, have it signed and witnessed, and that doesn't cost any money. So I'm not sure why somebody charge him 10,000.
Who wants the 10,000?
Lawyer.
Probably a lawyer. For an advance directive, actually, it's better to be witnessed by a medical doctor rather than to be witnessed by a lawyer.
The lady at the back, please. Yes.
I'm Helen Chen from School of Nursing, CUHK. So currently, I'm actually doing research on promoting advanced care planning with the patient with chronic advanced disease. So actually, most of them would like to share their views and would like to make advanced directive for themselves. But what I'm concerning actually is about our updated HA guideline for our clinicians. So especially for artificial nutrition and hydrations, because in the updated version, there is one paragraph saying that if they want to withdraw or withhold artificial nutrition and hydration, the clinician should be very conscientious of withholding or withdrawing this kind of treatment. So I'm concerning why the hospital authorities still want to put this paragraph asking the clinician to seek court decisions before we have our case in our community. Because this is also very confusing to the patient and the family member, whether it is really legal for us to let the patient die without a tube feeding.
What you mentioned is a paragraph in the first version of the guideline. This is not something newly added in the 2014 update. It is in the original 2010 guideline. And that paragraph is on non-terminally ill patients in persistent vegetative state, not in general. So that caution is raised by the HA lawyer. It is not raised by me. All right. This is a pure legal concern. Maybe I can explain more. The concern is restricted to non-terminally ill patients in persistent vegetative state and regarding an directive to withdraw artificial nutrition and hydration when PVS is diagnosed. The lawyer is concerned because in UK, the Tony Bland case, actually this is not really an exact parallel because Tony Bland did not have an advance directive. But in the Tony Bland case, the law decision and still recommended in UK and in Hong Kong is that in a patient in persistent vegetative state, withdrawing the artificial nutrition and hydration in such a patient needs a court judgment. The HA lawyer look at that case and worry that because there's no case law in Hong Kong about advance directive requiring the withdrawal of artificial nutrition in PBS state, so the HA lawyer add an extra caution to say that such a directive, if we see such a directive within HA as a first case, we may need to go to the court. So because they just wanted the court to ensure that this is whether we should really follow it or not. So this is a caution from the HA lawyer. So I hope I've clarified. But if the patient is terminally ill or in other situations, then withdrawing artificial nutrition hydration is similarly should be considered similarly to other life-sustaining treatment. There's no extra caution required.
Thank you for clarification.
Yeah.
But because my population is mainly those in early dementia and those with chronic disease, so they foresee that they may be in a irreversible coma, but not terminally ill state.
For dementia, then it's quite different from persistent vegetative state. Advanced dementia, we will have an update of the 2002 guideline. One of the specialists involved is here, Dr. Edmund Elsie. We will update a section of the 2002 guideline on the artificial nutrition and hydration. In that part, we will also go into the feeding problem in advanced dementia. So we hope when that is out, that then this issue might be improved, I'll say. What you mentioned, the restriction is really, the caution is really limited to those in persistent vegetative state and not including the dementia.
Thank you.
Well, not to worry. I will be talking about the case that he mentioned and PBS after 12 o'clock. I think there was a lady there.
Hello, my name is Elsie Hui, geriatrician from Sha Tin. Yeah, I'm glad Helen raised that issue about tube feeding in general. I think similar to restraint, we have far too many patients on tube feeding in Hong Kong. We're not talking about young people in the vegetative state. We're talking about old people with advanced dementia or having had multiple strokes. And it is definitely an ethical issue. So I'd like to invite the clinicians to comment about how, it's really very, very common tube feeding patients.
I'm not a clinician.
Tube feeding is another landmine of ethics. Yes, in Hong Kong, there may be, to me, I think there's many factors leading to this phenomenon. When overseas experts coming to visit our hospital or our residential care homes, they always have one comment. Why in Hong Kong there are so many tube feedings? And I've answered this question for 20 years, if not 10 to 20 years already. But I still cannot totally understood why. But there are several things I believe which is the case. One is maybe the cultural reason. The Chinese may like, they're not too ready to let the patient so sort of starving or dehydrating to death. One point. But I see more and more relatives nowadays choosing not to put in the tubes, and they choose comfort feeding now. Percentage around 5 to 10% in all my cases in the ward. So, but this brings another practical issues is if they are eating so poorly, can they be discharged back home or residential care homes? They're taking drugs like epileptic drugs, but they cannot take the drugs. So are we doing harm to the patients? So there are a lot of practical issues. In the residential care homes, especially those private homes, they may not allow the patient to stay there for long if they are not eating, okay? 1 to 2 days, 3 days, find that they are dehydrating, then they will go back to the emergency again. So another practical issue is they keep on going back to hospital. We call it a revolving door syndrome. And the other issue is the doctors themselves and the medical staff themselves, okay? Geriatricians know that. I just published a paper on aspiration pneumonia. There's no evidence that tube feeding can prevent aspiration pneumonia. On the other hand, there may be evidence that it causes more aspiration pneumonia because it keeps regurgitating and poor oral hygiene, that sort of thing. But in general, the doctors, you talk to a lot of other specialty doctors, or even nurses, they will still believe that, oh, this patient has swallowing problem, cannot eat. There may be aspiration pneumonia, so you need to put in a tube. This is not the reason, actually, but nutrition is the case, but not preventing pneumonia. But a lot of times they use the wrong reason to put in the tubes. There are many other reasons, such as the patient's, she has no advanced directive or advanced care planning. So when they put in the tubes, finally is the relatives or the daughter or the doctors who believe that it may be the best interest of the patient. But the patient himself or herself may have said something years before, I don't want the tubes, but no one remember, no one take care of this. So there are a lot of different issues going on. My personal view is always when the patient is advanced dementia, is the verge of whether put in the tubes or not, we need a family conference. If the patient is haven't made any decision before not to put in the tubes, whether they arrest the risk of aspiration, whether they allow the patient to starving to death, that sort of things. After careful discussions, we finally may or may not put in the tubes, okay? And the other issues is the staff in the hospital. In some of the wards, if the patient has been assessed by a speech therapist that has dysphagia, cannot eat, high risk of aspiration pneumonia, if the relatives have chosen not to put in the tubes, some of the staff refuse to feed the patient because they're scared that when they feed the patient, they may have aspiration and then they may be in trouble. So ask the relatives, oh, you choose not to put in the tubes, you come every day to the ward and feed the patients. We don't feed the patient. We are experiencing these sort of things happening in some of the hospitals. I don't know whether you have similar experience. So balancing all the things together, this is a different issues. But as a geriatrician, we try our best to accommodate accommodate relatives who have chosen, or the patient who have chosen not to put in the tubes. So we have getting more and more patients not putting the tubes actually nowadays for these sort of patients. I don't know whether Joseph have your own personal experience both in UK and in Hong Kong.
Yeah, my view is a bit more simple. By the time they are unable to feed themselves with severe end-stage dementia, they are within a few weeks or months of the end of their lives. So having a hard plastic thing stuck in the nose 24 hours a day is not what I would consider a good ending. And there is no good evidence out there at all from any research that it improves quality of life. They don't live better as a result of this intervention, which can have potential harm. And my worst worry is once the tube is in the nose, the handcuffs come out because they want to stop them pulling the tube out of the nose, because every time that happens, they have to be admitted to hospital. So this goes in the nose, this goes in the arms, this goes in a trunk. So one intervention which the family thinks is relatively benign, and it's about how you sell it as well, of course, when you discuss at the conference, leads to, in my view, a huge deterioration in the quality of life of that person during the last few weeks or months of that person's life.
Thank you. The lady at the back.
My name is Carmen, and I'm an ordained minister, and I'm a native from Hong Kong, but I was I've been in the States for 30 years. I was trained in professional chaplaincy, hospital chaplaincy, and I work as a chaplain in the States here. So I'm here just visiting, and I have a special love for Hong Kong. I don't like the heat. I don't like the humidity. I guess what I have heard, has a lot of resonance in me. And a few things I would like to say. I know it's a very big field, a big challenge to tackle. I feel like working on the ethics area is a shared responsibility. Chaplains are very involved in healthcare in the States. I can only speak for the States. Communication is also one thing. Yesterday I met with a family to provide grief support for them, and I was so surprised to hear that. The patient was diagnosed about a year ago, and she declined during the last 2 months, but they were not given information about how the patient was exactly doing. And communication is a big thing in the States, even among the healthcare team. So I have a few suggestions. I have a media background in Hong Kong in TV production, and when I came back, I looked at the programs. A lot of programs are not of good quality. When you look at the programs every day, what message are sending. So I would like to propose thinking about a public education. I have seen the pamphlets in Hong Kong, in the hospital in Hong Kong. They're well done. They're really well done, very informative, and has a lot of information on different diseases. And so I thought, well, this would be good, and the government, the Radio Television Hong Kong can participate in the public announcement, that kind of 1 minute thing, I used to work for Radio Television Hong Kong in the TV division. Yeah. I was involved in Hang Chang Zak, something like that. And also speaking to specific groups, even the media people, they need to be educated so they can think about, there are lots of good stories that can be produced through the TV station. And also for the healthcare workers, particularly in the deaf and dying area. My mother died in QE in 2008. I was not able to be with her, even though I had the skills working with other patients and family. My family told me that they need to go to the morgue to claim the body. And the body was dropped. When they opened the drawer, the body was on the floor. It's very, very bad. Kind of like you treat the body like that. And I don't know about the procedures about death in the hospital. But many subtle things can be improved. We don't have to wait until the legislation, to tackle the big framework. If we can have more private rooms in the public hospital for people who are dying, that can provide more time for family and to spend time with the patient together. Yeah. So this is one of these.
Yeah. Thank you. I think in the interest of time, you have to move on. But I think this relates to Dr. Luke's point about holistic care, not only focused on purely medical needs, but also the needs of the family. I wonder if you have any comments.
Yes. If the patients die, if it's not in our program, if the patient is dying in A&E, they are usually classified as death on arrival, and they will be put into they will report to the coroner, and then the body will be transported to the public mortuary. And we know that public mortuary conditions may not be as good as the mortuary conditions in Queen Mary. So we proposed to the mortuary of the Queen Mary that the body should be transported to Queen Mary. So they accept this logistics. So my program, all the patient's body after dying in A&E will go to the Queen Mary mortuary, which I'm not sure about other hospitals, but Queen Mary mortuary is old, but it's still a quite proper place. Actually, my father also passed through the Queen mortuary. I have my personal experience to collect my father's body in the Queen Mary mortuary. It's not modern, but all the body are in the proper place, and he was not on the floor actually. So luckily, yeah. Well, but I think after Queen Mary redevelopment, the mortuary may be even better. But now they're still in the renovation process.
Well, I guess what I'm trying to say is, I don't know about the procedures, but whatever steps it takes, it doesn't have to be that troublesome. Well, she died in the hospital, so why she had to be claimed? Why the family has to go to the morgue to claim the body? I don't understand. I mean, she died in the hospital. So, I'm not trying to nitpick like these details here, but the process can be more humanized, can be more respectful. This is what I'm saying, yeah. The other thing I can think of is...
I think we have to leave this topic for now. We have perhaps this time for one or two one-breath question. So if you want to ask a question, you have to say it in one breath. Oh. One breath.
Yes. If I'm going to die, I won't care about the coroner's ordinance. I've seen the movie, Japanese movie, The Departure. Yeah. If I'm going to die, and after I die, I know nothing. But if I know that I will be respected like that, that ritual is very soothing. I would like to know whether there is any business provider of that good service.
Thank you. Anyone in the business here? Well, I saw the movie too, and I rather like it.
Hi, I'm Cecilia Chen from Social Work. It's not a question, but it's an appreciation of the three speakers on this morning's sharing. I think it all the more give us a drive to continue pursuit the problems of defensive administration, the lack of coordination for autonomy, respect for quality of life at the end of life. The choice of where to die. Can we die at home currently? No, because you have to go through public mortuary and all that. Dying in an OH facility is also very, very difficult that Dr. Look have been working on. So there are a lot of things that we have to be working together to bring about change, and we definitely do not want for our next 20 years to explain to other people why are there such numbers of tube feeding, why are there such numbers of restraint in the OH homes and elderly facilities, and to exercise what we all want, to die at home in a decent, respectable, dignified manner. Thank you.
Well, I think we have to end here now. We have just half an hour for tea break when we resume at 12. But I think I can fairly summarize, I think, for all of us, that we are of one mind in wanting to find ways towards a more human end that does not focus so much on medical or ethical or legal concerns, but on the person of the patient, herself or himself. Thank you. I'll see you back here at 12.